Hi, Gordon's about to stop. Hi, my name's Laura and I'm the current HDU Link lead midwife in Southampton. And this is just a session about CVP lines and arterial lines. And we're going to do a quick tour around our HDU so you get some idea of the necessary equipment that you're going to need. That we're going to upload the PDF after this so that you can take it away and have a read. Okay. So the aims of the session are to enable you to be able to care for ladies that have got central lines and arterial lines, to be confident in it, remembering at all times that if you've got any questions, please ask. Your coordinator should be able to help you, or your anaesthetist or the ODP, because generally it's the ODPs that make our machines work. We are going to teach you how to reduce the risk of infection and how to also safely remove central lines. So a central line is an intravenous line where the tip sits just above the right atrium in either the superior vena cava or the inferior vena cava. The purpose of it is to reflect the volume of fluids going around your body so that you can understand if the lady you're caring for is underfilled or overfilled, and how to care for them appropriately. Main reasons to have a central line are access. That's the number one reason that we use it here at Southampton, as opposed to measuring actually their CVP pressures. Talking to the ITU guys, they will often tell you that they don't use them for measurement. It's an outdated process, but this is quite site specific, and there are other units across the region that do measure the central lines, central pressure volumes. They can be used to administer fluids and drugs, especially those that can't be given peripherally, like inotropes and amiodarone. You can use it for feeding. You can take bloods from it, and we use it predominantly in Southampton for poor venous access. So our IV drug users that have got no other access, I've definitely cared for women where they have had a central line because there are no other ways. There are risks associated with central lines. Big ones are hemorrhage, pneumothorax, cardiac tamponade and arrhythmias. Infection is, again, really important. Misplacement. I have seen central lines put into arteries before in a hurry, because they're very rarely put in because you've got a well woman. They're generally put in because somebody's not very well. You can get an air emboli or an emboli at the bottom of the catheter. They can be pulled, they can move when they're in position, they can become greasy and grubby when the people are sitting there sweating in beds. So they are a risk, and they are never ever put in without a full risk assessment. So when you put one in as a midwife, clearly you're not expected to put them in, but you are expected to be able to assist the anaesthetist. They're generally put in theatres, but I have definitely cared for women in HDU that have required one for whatever reason. The last lady I looked after was particularly septic, and she had it put in HDU because she was too sick to transfer elsewhere. So you are going to want your CVP pack. You are going to want some Chlorhex, which is a 2% solution, or a snap stick with a pad on the bottom. You're going to want an ultrasound machine, sterile gloves, gown and mask, local anaesthetic. You're going to want a transducer set run through with a 500 ml of normal saline bag, and you're going to want a pressure bag set to 300 millimeters. You want the transducer cable, and you need it to be able to plug into your HDU. Okay, so my one piece of advice is make sure your HDU or your HDU area is particularly well stocked, because if you're putting it in a hurry and you are running around for leads, then you're delaying the process. So as I've said, uses are for estimating circulating volume. They can be used as a guide for fluid administration. Again, I would say in Southampton, we probably don't use it for that reason. We use it as an access point when we've got very poorly ladies. The reading of central venous pressures should be done as a trend and not as a singular one-off an assessment. And actually, while you take the assessment of the CVP, you also need to be looking at the bigger picture and actually how is the lady responding. So looking at taking measurements and looking at the waveforms, you need to explain to your lady what you're going to do. you need to flush the line to make sure that it's patent and that it's working correctly. And they will feel that you are flushing it. They'll get a cold sensation in their neck, and it sometimes can make them feel a bit woozy and not very well. A bit like when you've got an arterial line, and when you flush an arterial line, their arms will often tingle and they feel like they've got pins and needles. Position to a supine position. If where possible, align your transducer to the 5th intercostal space, and check the CVP line and document document what you find. So increased readings in CVP pressures. It can be that your lady is hypervolemic. She's got forced exhalation, so she's really puffing off all her CO2. She can have a tension pneumothorax. She could be in heart failure. She can have a pleural effusion, decreased cardiac output, or she could have a cardiac tamponade. And whereas a decrease in readings, as you can see, is that she may be hypervolemic, or that she may be breathing particularly deeply for whatever reason. I mean, we all know that we've cared for women where they very rarely, post any major operation or feeling generally well, they won't take big, deep breaths, but occasionally these women surprise us, and they do. So the most important thing I would say about care of a person with a central line is don't use one unless you're happy using them. If you're unhappy, find somebody that is more comfortable caring for these ladies. Document any changes that you've done, document where you have changed the dressing, document that you have checked that it's not red, document that it flushes correctly, make sure that any procedure you carry out with the CVP line is done so sterilely, and that you document that you are doing so. There are specific forms across the region, a bit like VIP forms. These will be evidence that you have looked at the site and that you've looked that it is not red, it's not swollen, it's not inflamed, the dressing is correct, and that the lady isn't complaining of pain or any strange feelings, particularly when you're flushing or giving anything through it. The whole transducer set needs to be changed every 48 hours, and ensure that all the ports are nice and secure, because they can work their way loose. To remove them, it's quite simple. It's just you need to remember all of it. So everybody's guidance is slightly different around the region. The most important thing to remember is lie your lady as flat as they can, or it needs to be flat. So just to take care, make sure they've got some analgesia on board if they are post-section. Carefully remove the dressing. You'll find that they're tied into the neck with a little suture, so you'll need your needle cutter, cut under the suture, and then take that away. And then as you remove it, one swift movement, get them to take a big deep breath in, and that way you are reducing the risk of cardiac air embolus. Sorry, my brain has just died. I'm on mat leave. Keep pressure on the neck for 5 minutes, and then check that it's not bleeding and dress it appropriately. Keep it nice and clean. Most important, before you remove it, check their clotting factors, especially if the girls with PET. Make sure that actually they're normal and returning to normal before you remove it, because there's nothing worse than trying to remove almost somebody that all's going to bleed. Okay, arterial lines. So arterial lines are more commonly used around the region. Personally, I love them. They are an excellent way of measuring how well somebody is. And yes, it's an invasive procedure, but actually once it is in, it means that it's a much easier process for the lady and for you actually. So the advantages of them are that you get beat-to-beat measurement of your blood pressure. You can take frequent blood gas samples. You can take frequent blood samples. They are more accurate if you've got an heart arrhythmia or if you are hypertensive. They are very useful in our big ladies where it's very difficult to get a blood pressure reading with a cuff, and we all have thigh cuffs, but we have all cared for ladies where a thigh cuff just doesn't cut it, or they are hot and sweaty and you are having to take blood pressure readings every 15 minutes. Sometimes it's just physically not possible. And you obviously need information about their cardiovascular status. So what is their clotting? Is it completely off, or is it reasonable to put in an arterial line? So equipment you're going to need for it is you're going to need your arterial cannula. You're going to want a fluid-filled tubing. I'll show you all this equipment behind me in a moment. This is the set that you're going to need. You are going to need to make sure that you've got your pressure bag, some normal saline. You're going to want your transducer set, and you are going to make sure that you are able to make the whole process clearly labelled for the lady. Common sites are the radial artery or the brachial artery. I think I've seen one once in a femoral artery, but it needs to be a constant position because the lady is going to be using it, and we are going to be using it a lot. It's much easier if it's in the back of the hands, so that you can access it, so you can see it, so that you can see that it flushes, so that you can take your blood samples easily, and so that it's vaguely comfortable for the lady. It's a painful process, but actually once it's in, the pain does resolve. It's a much smaller cannula than the 16 gauge cannula. If I can show you here, you'll see. Excuse me. That's the cannula that goes in for an arterial line. And different trusts have different sets. Here in Southampton, this is the set we use. But I know coming from Poole, this is the set that is used in Poole, and it's all slightly different. All does the same function. Sometimes taking bloods from the ports are different. Here in Southampton, it's a lock system, so there are no needles involved, and I'll show you about that in a minute. So potential complications. Bleeding to the lady if the tap's left open, bleeding to the lady, especially with the closed systems, if you take off a blood bottle and you still have your bung in to take it. I'll explain that in a moment. Incorrect sighting, tissuing, infection. The biggest risk we have here in Southampton is that it works miraculously in theatres, which for some of you will know is about 100 yards behind me. They do the magic walk up the corridor, they come into HDU and it stops working. At which point I either cry, get an anaesthetist, or ask the ADP to come and help me. And generally between the three of us, we can get it working again. So that's just to bear in mind. So caring for ladies with arterial lines, observe limb perfusion, make sure it's not occluded, and that, or you've got anything tracking. Remember, you cannot give drugs through arterial lines. Lots of people think that actually you cannot. It is a take-out system. It's not a put-in system. Okay. Make sure that you are taking blood samples using a sterile technique. All ports need to be secure. Change your whole setup within a system within 48 hours. Change your fluid bag every 48 hours. Change the whole system every 5 days. Change the dressing as per local guideline, but actually they're probably very rarely in for longer than 24, 48 hours here across the road. If they need to be longer because they're sicker, maybe I would argue that HDU is not the best place for them, and they need to be in a major and intensive care unit where they are used to looking after them daily, hourly. Ensure no aerial bloods in the circuit, and it should be I laugh as I say this, a one midwife to no more than 2 women when you're looking after this. I do appreciate, especially at the moment, that is definitely not always the case, but you shouldn't be expected to look after her and 2 or 3 other people. Okay, every 4 hours with the CVP and arterial line, your monitor behind me needs to be 0 to calibrate them to check that they're reading okay. You also need to make sure that you are able to take a manual blood pressure at least every hour to make sure that actually your arterial line and your non-invasive blood pressure are measuring at the same or a very similar rate. I've definitely seen where a blood pressure cuff doesn't register what an arterial line is, so we need to make sure that we're actually giving an accurate representation of what this lady's blood pressure is. So you need to flush the system. I'll show you all the demonstration in a moment. Flush the system, level the transducer, align it with the 5th intercostal space of the lady, turn the tap onto the closest transducer so it's off to the patient, remove the cap so it's open to air, and press the 0 button. What you'll see on the monitor is everything sort of clears, and then it will come back in gradually and it should all read properly. When you're doing that, explain to the lady what you're going to do, because as you flush the system, you'll see that the skin will blanch up her arm and it just feels funny, and it is a momentarily thing. It will last probably 20 seconds, if that, and it will go and she'll be back to normal. She won't even know that you'll do anything with it. Okay. So arterial line tracing, it reflects the pressure generated in the arteries following ventricular contraction and relaxation, giving systolic, diastolic, and mean arterial pressures. The dichrotic notch on the downstroke is the end of the systole and closure of the aortic valve, which varies according to the timing of the aortic valve closure during the cardiac cycle. Okay, troubleshooting. I laugh as I say this. The biggest one will be it's just not recording and that you need to zero it. So make sure that you're happy with zeroing what you've got. If you can't get anything back on it, you need to just, when you try to take samples, check the position, just give it a gentle wiggle and see if it's just that it's got a kink in it somewhere. Falsely high readings, just play with the transducer. On your monitor, you'll have top and bottom lines, and you want to make sure that your waveform is between those lines. It's not particularly peaked or sluggish. It has to be a lovely regular waveform, and that will give you an understanding that you're recording it accurately. Yeah, they're the biggest troubleshooting tips I can give you. When you remove it, firstly check the clotting of your lady, ensure she's still got some peripheral access, because often we take out the arterial line and it's a gradual work down back to normality. So make sure they've got good working cannula. It doesn't necessarily have to be a 16 gauge cannula, because hopefully by that point she's not on great volumes of fluid. It may just be some IV antibiotics. So make sure she's got some access. Remove the dressing, and that's often the most painful bit. Slowly remove the plastic tubing that's left, and apply pressure and hold that pressure for 5 minutes, because they will bleed. Dress with gauze and clear dressing, and check that on the NTV catheter that it's complete. Just check for pressure signs that you would do with a normal cannula. Document on your forms that you have removed it. Any questions? Once I have got set up, I am going to give you a run through of how to set up the arterial line, so you should feel a bit more confident with it.